Great pleasure in presenting Dr. Amjad Maniar from Bangalore, consultant anesthesiologist at Axon Anesthesia Associates for multiple hospitals in Bangalore, lead consultant anesthesiologist at Peopletree Hospital. He's the coordinator of AORA Sonosite Fellowship Program in India. He's in the member of the editorial board of Academy of Regional Anesthesia of India, scientific committee member of the Academy of Regional Anesthesia of India 2016 National Conference at Hyderabad.
Good afternoon, everybody. I'll be speaking to you about continuous spinal anesthesia and how I perform it in my clinical practice. My sincere thanks to Dr. Balavenkat and the organizing team of GARC 2020 for inviting me to give you this talk. I have nothing to disclose. Continuous spinal anesthesia is a little bit of the dark arts in regional anesthesia. It's been around for over 100 years, but it isn't very popular. It's not practiced as much as it probably should be, mainly because there are a lot of misconceptions regarding the complications that can ensue with such a technique, as well as the difficulty in procuring the equipment required to perform it. By definition, continuous spinal anesthesia is the technique of intentionally producing and maintaining spinal anesthesia with very small doses of local anesthetic, which are injected intermittently into the subarachnoid space via a catheter. However, it is not a technique where an inadvertent dural puncture is made during epidural space placement by inappropriate skill or otherwise, the subsequent insertion of the catheter in a desperate attempt to prevent the PDPH, which is sure to follow, the administration of a large bolus of local anesthetic, 2 to 3 ml once the catheter has been placed, and the perennial confusion that ensues after you do this, whether you should take the catheter out or leave it there for a couple of days. So continuous spinal anesthesia is very specific, it is very intentional, and it is a pure technique. I mentioned that the technique was over 100 years old. The first description of continuous spinal anesthesia was done by Dean, a British surgeon in 1907, who wrote about placing a needle in the subarachnoid space and leaving it there so that the local anesthetic doses could be repeated and he could operate for however long he desired. In 1940, Lemon described a technique where he used a soft and bendable needle which he inserted into the subarachnoid space and connected to red rubber tubing which he laid out onto a trolley where he could aspirate and re-inject the local anesthetic when desired. He also described how he made a groove in the mattress so that he could channel this red rubber tubing without kinking it against the patient and the mattress. A few years later, Major Toohey, who we all attribute our epidural needle to, described the use of placing a uretral catheter within the subarachnoid space to perform continuous spinal anesthesia. But it was in the 1990s when Hurley and Lambert described the same technique using a microcatheter. Now they described using a 32 gauge catheter which had a 35 gauge stellate which was inserted through a 22 to 26 gauge spinal needle. And they wrote about using this technique in 24 patients. They encountered certain problems which we also still encounter to this date. There was difficulty or inability to place the catheter. The catheter broke and remained within the patient in some cases. The catheter moved out of the subarachnoid space. Patients developed PDPH. The catheters, because they were so fine, started to kink and they were unable to inject the second dose because of this. And in some instances, they were not able to pull out the stellate once the catheter was in place. But more than those niggles, It was the cauda equina syndrome that followed that brought about the unpopularity of continuous spinal anesthesia. In 1991, the first cases of cauda equina syndrome were reported. There were two papers that described 6 cases, all of which involved a rather large dose of hyperbaric lignocaine, about 350 milligrams of it. And in each case, there was a specific pattern. The initial bolus that was given for the spinal did not lead to an adequate spread, which resulted in the practitioner giving larger and more frequent doses, all of which totaled up to the 350 milligrams. Subsequently, 8 more cases of cauda equina syndrome were reported, and in 1992, the FDA in the USA banned the use of spinal catheters smaller than 24 gauge. Now, what exactly is this cauda equina syndrome in relation to continuous spinal catheters? When a microcatheter or any catheter is placed within the intrathecal space, it can travel towards the head end or it can travel caudad. And when the catheter travels caudad, there is a possibility that it may get wedged within a nerve root or within the cauda equina, which is the terminal part of the spinal cord. You must remember that these catheters are ridiculously thin. They can be as thin as 32 gauge, or commonly we see 25 gauge catheters these days. And they're about 100 centimeters in length, just like your epidural catheter. When you try to inject through such a thin catheter, there is immense resistance, and the local anesthetic that comes out of the tip of the catheter comes out in a slow trickle. And this leads to the local anesthetic pooling at that exact point where it comes out of the catheter instead of diffusing into the CSF and all around the subarachnoid space. So this pooling, and it is more pronounced with hyperbaric lignocaine or any hyperbaric solution, causes neurotoxicity. Therefore, cauda equina syndrome is a result of the abnormal pooling of local anesthetics, the use of very high concentrations of local anesthetic, hyperbaric solutions, and multiple or large boluses after the initial failure of effect from the first bolus. So all this is a predisposition to neurotoxicity, and it results in cauda equina syndrome. One of the main reasons why continuous spinal fell into disrepute was the use of very high doses of hyperbaric lignocaine. Lignocaine, we know now, has been implicated in transient neurological symptoms even with single shot spinal anesthetics. The preference in continuous spinal anesthesia is to use other local anesthetics like bupivacaine or ropivacaine in regular or low concentrations, and hypobaric or isobaric preparations are preferred. Now, why would you want to use a technique that is fraught with so many complications? Well, for starters, if you exclude peripheral nerve blocks, continuous spinal anesthesia is a very hemodynamically stable anesthetic technique. There are multiple reports on its use in patients with aortic stenosis, carotid stenosis, in high-risk laparotomies in the elderly and compromised, and in my opinion, it is far more stable than even a good general anesthetic. The quality of the anesthesia is very, very high. It's just like a spinal. And you don't use the kind of doses that you do with a spinal anesthetic or even an epidural if you want that sort of surgical quality. There's no limits to the duration of anesthesia because you have a catheter in place. It can be used for post-op analgesia, but that has its own issues. But despite the horror shows of the 90s, modern day continuous spinal anesthesia does not seem to have the same complication profile as it did back then. These are some recent papers that are available, and you see that the present day the complications are mostly failure to insert the catheter, PDPH, paresthesia during insertion. These are the kind of niggles that you get when you do the continuous spinal technique, mainly because we have gone past the use of lignocaine and hyperbaric solutions, and the incidence of cauda equina syndrome now is very, very minimal or perhaps non-existent in recent literature. Coming to techniques. Now, there are two systems that you can use to place a catheter. The catheter through needle systems and the catheter over needle systems. I'm just going to show you a demonstration of both these catheter systems in the following slides. The first kind of system is a catheter through needle system. Most of you are familiar with this sort of system. It's the same sort of thing that you use when you place an epidural. But what we use with continuous spinal is microcatheters. Usually these systems have catheters that are 25 gauge and smaller in size. The needle type also varies. It is usually a spinal sprotte type needle that is placed intrathecally, and then the catheter is deployed through this needle. The angle of the needle exit with the sprotte type is very conducive for optimal positioning of the catheter. It's technically a simple and straightforward method to do. The microcatheters, because they are so thin, are prone to kinking. The catheters can be as fine as 32 gauge. And though these catheters originated in the USA, they are presently banned over there. So this is a microcatheter spinal set. This is a catheter through needle system. This is made by a company called Payung, and it's easily available in India. It consists of a 22 gauge sprotte needle, very important 1 ml syringe. The catheter is wound up in a frame and comes with a guide wire. This particular catheter is 25 gauge. The usual connectors are present, and there's a skin lance prior to insertion of this protein needle. So this is a video of how the continuous spinal catheter is placed. So we paint and drape the back. There's a little bit of local anesthetic that goes in, just like you would in a regular spinal. This is the introduction of the sprotte spinal needle. And with such a large needle, you should expect a very free flow of CSF. Once that is done, the catheter is moved out of the frame and gently inserted through the spinal needle. You must be careful not to force the catheter. It has to travel in smoothly. At this point of insertion, you can expect the patient to jump or have some sort of jerks. These are very transient and they don't usually lead to any long-term problems. So you can see the catheter is being inserted very carefully, and now the needle is being removed. Usually you can leave about 3 to 5 centimeters of the catheter inside. We like to keep the entire frame and needle on a nearby trolley so that we don't inadvertently touch the catheter anywhere. The connector is fixed. That's the catheter being adjusted. And we gently aspirate with a 1 ml syringe. It's very important to use these small syringes because too much negative pressure would result in no CSF coming. So it has to be a very gentle aspiration. And you can stick the catheter on as you would with just like an epidural. The other sort of system is the catheter over needle system. You may have heard of these being used for peripheral nerve blocks these days, but the use of the catheter over needle system has been around with continuous spinal for a while. These are much larger gauge catheters. They're 25 to 27 gauge, and they're also much shorter. The previous catheter that you saw was about 100 centimeters. These are much shorter. And the key part here is, in terms of technique, the deployment of the catheter takes place after initial entry into the epidural space. So we do not want the catheter shearing as it goes through the ligaments in the back. So we create a channel into the epidural space and then pass the catheter through this. Because these catheters are shorter and larger, the flow rates are much better. So the pooling of local anesthetics causing cauda equina syndrome is completely reduced. However, these catheters are also prone to kinking, and because it involves a catheter that is larger than the needle, they have been allegedly designed to reduce the incidence of PDPH, but this has largely been unproven. These are FDA approved. So this is an example of a catheter over needle system. This is made by a company called Wiley. It involves having an 18 gauge 2He needle with a peel away sheath, a 25 gauge catheter over a 27 gauge spinal needle, something called a wick wire, which actually stents the catheter open to prevent it from kinking, a fixation device, and a syringe for LOR. This is a closer look at the components. This is the spinal needle with the catheter on top. And this is a closer look at the braided catheter that you see here. This is the sprotate tip. This is a closer look at the 2He needle, and take note of the peel away sheath that is seen riding on top of the needle. This is the wick wire. This is inserted into the catheter once the catheter is inside the intrathecal space. It's kind of like a stilette, which allows you to also inject through the catheter when it's in place. It helps prevent the blockage of the catheter when there is kinking. So this is a demonstration of this system. So this is accessing the epidural space. Once the epidural space has been identified, the 2He needle is removed, leaving the sheath as a channel that goes right into the epidural space. Subsequently, we insert the spinal needle along with the catheter. So after you do that, you can pull out the stilette and wait for the CSF to come out of the needle initially, and subsequently you see the needle being removed, and you should see a drop of CSF trickle out from the catheter, which is right now in place. You can see the CSF coming there. Once that is done, the catheter is slowly pushed further into the intrathecal space, and then the catheter is gently peeled off. The sheath is gently peeled off. You can see, if you notice, you saw the patient's jerk over there, probably feeling a bit of paresthesia. This is the sheath being peeled off, and the wick wire system goes in now. Subsequently, the conduct of the spinal anesthesia is same as described before. So when you use an intrathecal catheter, you must have a plan as to what you're going to be doing about the initial bolus, how you maintain the catheter, and whether you want to keep the catheter in the post-op period. So it's very important that you estimate the dead space of the catheter prior to doing the procedure. Most of the catheters have a priming volume of about 0.3 to 0.4 mils, and the initial bolus in hemodynamically unstable patients is about 0.5 mils. So you add the priming volume plus the initial bolus. So for example, you might get about 0.9 ml to 1 ml as your initial bolus, and you assess the onset and response and top up accordingly. Intraoperatively, you can top up the catheter with 0.5 mils of local anesthetic when needed. In the postoperative period, if you do have the facilities to maintain the catheter, you can keep it and use it to provide post-op analgesia, or you can do as I do, which is just remove the catheter. If you're wondering how long you should keep the catheter, well, you must remember that all catheters, whether spinal or otherwise, get colonized up to 57% of times, and there's a small risk of infection that will always be there. There is probably no data on infections related to continuous spinal catheters. Most practitioners will not keep the catheter greater than 24 hours. As I said, I personally pull out the catheter at the end of the case. Other forms of analgesia like a peripheral nerve block can be given to provide analgesia in the post-op period, and it's not necessary you should keep the catheter. If you do decide to keep the catheter, you might require specialized pumps to ensure that the low volumes of local anesthetic are accurately delivered. Some studies advocate the use of 0.0625 to 0.125% bupivacaine or levobupivacaine at about 1 ml per hour. You can add opiates like fentanyl to the solution. And patient-controlled continuous spinal anesthesia, specifically analgesia, has also been described. So what are the major issues that you should be worried about? PDPH in the susceptible population, young patients between the age of 14 to 40, 50 are not the best candidates for continuous spinal anesthesia. I do not advocate to use this technique in younger patients. And when you start using this on elderly and higher risk patients because of the difficult spinal structures, it can become technically very challenging to perform. There can be a high incidence of paresthesia during the placement of these catheters, but these do not give you long-lasting issues. In the post-op, there is a possibility that somebody mistakes it for an epidural catheter and injects large volumes of drugs into it. This can be devastating. Risk of infection is there, and there's a small risk of breakage of the microcatheter. So my tips for success with continuous spinal are: use this only when you're pretty good with your spinals and epidurals. This is not something for the novice anesthesiologist. Use the approved catheter sets, though there are publications that advocate the use of epidural sets. I don't particularly recommend you driving an 18 gauge 2E needle through the dura. Use it only in cases where you really need to, where hemodynamic stability is warranted, and pretty much don't try using this on young patients because your risk of complications are just going to increase. Always use a 1 ml syringe to aspirate. Estimate the dead space of the catheter beforehand, and very important, use hypobaric or isobaric solutions. Do not use lignocaine. I hope this talk was informative. Thank you for your attention.